Thanks very much, Benedetta, and thank you to all of you. Turns out the only reason I had to leave is because there are several meetings happening back up at WHO. You know, when you're in your own home, you have sort of your family and your other things to deal with. When you travel, you leave all that behind briefly and you're able to focus just on the conference. My family up there, including our mother, Dr. Chan, has called us for a meeting on MERS and for a few other things, but it's been shifted around, so I'll be able to stay as long as I can, so I won't have to leave right afterwards because there's an excellent panel, some of whom I worked with through the Ebola response. And my job for this presentation is really to present to you briefly sort of the picture and set the stage for our work in the Ebola response and the general picture on the Ebola response. Now, many of you were in these countries, the people up here were in these countries, and so they'll present different viewpoints. And I think like any major public health effort, the viewpoint can vary very significantly depending on where you were standing, whether you were working with communities, whether you were working with international organizations on issues like points of entry, or whether you were at the bedside taking care of patients. And I think the goal of this pre-session is to see what lessons can come out of this that can point us forward. I think we stand, just before I start, at a very determining moment for, not just for the World Health Organization, but for all of the organizations involved with infection prevention and control. I've worked my whole career, which is getting longer and longer, my daughter reminded me the other day, in quality, safety, and particularly around the issues of infection prevention. And I've never seen a moment where there was so much attention on IPC as the heart of safe delivery of healthcare and at the heart of broader issues of health systems. So what I'd like to do is just frame a bit some of the numbers and the general response, at least from WHO's perspective, on Ebola, and then use that as a framing for the more specific presentations that follow. Now, those of you who have worked in this arena are familiar with the issues that are marked on this slide. It lays out some of the broad major infectious threats in the 21st century, looking at time back in the beginning of the millennia where we were forming major initiatives such as Gavi, GOARN to respond to vaccine-preventable diseases as well as outbreaks, the launch of IHR in 2005 and the PIP framework then in 2011. In the background of these, you can see were these outbreaks that happened. Each time there was some momentum that was created based on a major outbreak, or in this case, H1N1 on the pandemic. And unfortunately, I would say as an international community, we haven't got it exactly right. Clearly, one of the lessons that's come to WHO over the past months has been that the lessons of the past have not been entirely learned. Then in terms of the epidemiology as of today, or at least of June 9th anyway, with the numbers stopping for Liberia on May 9th, these are the totals that we see in terms of confirmed, probable, and suspected cases. A total caseload of 27,251, and the cumulative deaths now well over 10,000 and over 11,000 across the three countries, with a different picture of the epidemic in each of the three countries. Currently, however, though, whereas the epicenter, as people knew, was perhaps in the tribe country region at the beginning of the outbreak, it's really migrated now to Upper Sierra Leone and to Bas-Guinea, where we have continued cases in Forocaria. And having just spent the afternoon talking with some of our team who've just come back from Forocaria, the issue now obviously is not management of massive numbers of Ebola cases in Ebola treatment centers, but it's the issue of regular standard precautions and infection prevention and control in regular health facilities. And the community, which I'll come back to as one of the core bits, still does not trust the health services. You have major district hospitals which would have packed maternities before this outbreak, having perhaps one consultation for the entire hospital per day. As I mentioned, there were many first-time elements in this particular outbreak. It was an enormous, just in terms of its size, the number of countries involved, and also in terms of the international spread. There were exported cases in 6 countries, and there was, because of that, and some of you here live in countries where there were isolated imported cases, there was incredible media attention on this, and there was a very, how should we say, irrational fear that existed there. And speaking with colleagues at CDC, when the case was brought to Emory University for treatment there, and the entire highway from the airport was closed. There was a police escort for the ambulance that came in, and I was talking to a friend of mine, and I said, well, what was the general impression of what was going to happen? And this is someone who's not in infection prevention and control. He said, well, what if the ambulance, turned over? And I said, well, he's not an atomic bomb that's going to explode Ebola all over, that part of Atlanta. But there was this incredible fear that existed. There was an unprecedented international response, and the community approaches were not a new effort, but really became part of the response in a way that other outbreaks, they haven't been. Finally, there was this, as there have been in previous outbreak work, but in a different way, there was a major effort on research and innovation, which continues today. Actually, our colleagues are still working in Guinea on the vaccine trials that are going on there. One of my jobs is also to spell out the roadmap as it existed for WHO and the different elements that were part of it, which might frame the discussions that come after. So the 3 main objectives of the roadmap were to achieve full geographic coverage with complementary Ebola response activities, to manage in those Ebola countries the widespread and intense transmission, and then to ensure emergency and immediate application of comprehensive Ebola response interventions in countries with an initial case or with localized transmission. And this was the case, for instance, in Mali, Nigeria, and I'll come back to that. Finally, there was the strengthening of preparedness of all countries to rapidly detect and respond to an Ebola exposure. And these were countries like Spain, the US, that worked on strengthening their own preparedness efforts. To go through a couple of the key activities and what this meant. So in terms of applying the full Ebola intervention package, there was work on case management, diagnosis, surveillance, burials, and social mobilization. 5 main strategies that were there. The work in case management focused on Ebola treatment centers with full infection prevention and control. So these were centers only for Ebola patients. Then secondly, a second tier from that, referral and isolation centers, and then a referral process from primary care facilities. The case diagnosis was by a WHO-recognized laboratory. As you can imagine, false positives would be a matter of life and death for people who are in these areas in terms of their isolation or referred isolation to treatment centers. Surveillance was another issue that built on weak surveillance systems that were there really trying to strengthen contact tracing and monitoring. Now, one of the efforts that people saw, given the nature of the infection, was a major effort on burials. And I think a lesson that we've learned is obviously supervised and safe burials to an international expert mean a very different thing for communities. Social mobilization then was something that was put in place, but unfortunately much later than it should have been. The effort now is very much ramped up, and I think this is one of the lessons that was learned, that this was not fully engaged. In terms of the strategy 2, there was the same 5 areas, but different elements that were part of it. So the complementary approaches in terms of case management included community-based care, and these, in some of the areas, included what we termed complementary care facilities or community-based care that were in some cases just facilities, not health facilities, schools, other ones that were set up with minimally trained health personnel that could provide some possibility of isolating cases other than staying within their homes and within their families. There were case diagnosis work using epidemiologic data that was then confirmed by WHO laboratories, surveillance in terms of monitoring new transmission chains, extended work on burials and on social mobilization to complement some of these approaches that put care into the community. And I should mention briefly that depending on the country, for instance, in Liberia, one of the factors that our team felt was a major change, and it was a bit controversial at the time, was basically giving these home kits out to families. There was no way to build enough or set aside enough complementary care facilities. People were having to care for family members who were suspected cases in their home. So what possibly could the international community do? So we gave them kits that included gloves and a minimal sort of information on how to isolate and care for patients in terms of palliative care while they were being followed. In terms of some of the priority roadmaps on the measures to limit national spread, there were specific programs within containment areas in terms of looking at, and in some cases this involved, based on national authorities' decisions, deciding to close off certain areas, bringing in food. We were a partner with the World Food Program who helped us both on logistics for medical care, but as well as on moving food into some of these areas. Then in terms of non-essential movement in and out of the containment area being stopped, ensuring that the essential movement continues unhindered. The mass gatherings were deferred, generally speaking, until the transmission was reduced. Now, in terms of the travel, there were recommendations under IHR in terms of prohibiting Ebola cases and contacts and implementing and monitoring exit screening at international airports. And there was a lot of discussion on this. I think one of the things that the countries realized is that outbreaks are not just a health issue, it's a major economic issue the minute that these flights start coming in and out of the country. And this is actually what resonates with ministries of finance. Often we spend our times talking amongst ourselves, experts here, for good reason. We then reach out and try to get to decision makers within ministries of health. Almost never do we reach out to the true decision makers in government, which happen to be behind at the executive level or the Ministry of Finance level. Some of the activities on essential services included laying the foundation for the health sector in terms of recovery, and I'll finish with that in just a minute or two, that the short-term capacity in terms of critical gaps on essential services, and these would include some of those listed, was filled by working with NGOs, other UN agencies, humanitarian organizations, doing what in some cases has been, in some countries, has been done similar in Afghanistan, where different NGOs were basically assigned different geographic districts and asked to help support. Long-term, that was not the vision. The long-term view was around the creation of these investment plans, health sector recovery plans that were developed by the country with support from WHO and other partners, including the World Bank and other international organizations, that were then presented. They were first drawn up here in first meeting in December 2014, and then they were presented at the World Bank meetings just this spring for financing. And there's a follow-up meeting happening just in July, on July 10th, by the Secretary General, looking at investment to strengthen the health services. This shift to the community approach, I think, is one of the main issues that we've really focused on, and some of the other speakers will also discuss, in terms of looking at how the intervention package could be brought, sort of, strictly speaking, out of just the health facility and involving both family members and the community in terms of contact tracing, in terms of being involved in burial, and also in terms of community care and caring for family members. For instance, assigning one family member who could come to the community care center, get guidance by a health worker, and then work with their family member while they were recovering. The laboratory support and community engagement were cross-cutting issues. Now you can see this is the application of the different interventions, where we had a low level and really only in sort of 1 to 2 countries at the beginning of the outbreak, and then a massive taking off of the number of cases, where there was a big scaling up of standard measures, but then also community measures, and with a much greater emphasis in the second or the third third of the outbreak in terms of community ownership, case finding, and contact tracing. Obviously, this is not superimposed to imply causality, but it was a shift in tactics that corresponded with a major diminution of the number of cases on a weekly basis. These interrelated elements of sort of service delivery, planning and implementing with communities, and then service uptake had health promotion aspects and community engagement aspects. And some of the other speakers will talk about this, but WHO spent a major effort investing in, again, later than it should have been, but investing in anthropologists accompanying our case-finding teams in order to work with communities and reach out to communities looking at their motivations and concerns with having these, what were in a lot of ways viewed as outsiders coming in to follow up on their community members in terms of being ill. In terms of the response, there was a major effort in terms of the numbers. It was the biggest effort WHO has ever been involved with, that I've ever been involved with, in terms of technical support and treatment being put out there. We had over 2,000 experts to the high transmission countries, many of them working through the Global Outbreak and Response Network. We had foreign medical teams that were brought in, and these are entire teams that are brought in and planted, who then manage Ebola treatment centers, manage certain sections. There were over 2,000 medical staff. And currently, a lot of people, including some of my colleagues at WHO, are under the unfortunate assumption that we're pretty much done and everyone's come home. And we actually have a lot of people still out there in the field, over 1,000 technical staff and 60 field sites. In fact, Benedette and I are asked to be part of a planning meeting for the team leads in just a couple weeks' time. That'll take place in Freetown, looking at next steps and implementation. In terms of treatment, there was support to over 66 Ebola treatment centers, more than 800 community care and holding centers. Now, I didn't put the slide up that looks at the really building out the corresponding slides, looking at the building out of beds and the number of bed availability and the falling in terms of transmission. But that's an extremely interesting slide to look at. We can discuss it some other time. But there were over 4,000 clinicians and health workers trained, and a staggering amount of PPE. That was personal protective equipment that was distributed. As someone who was not that involved with personal protective equipment and its specifications before this outbreak, I can't tell you how much I know about it now. We've had endless discussions about it. Now, clearly, personal protective equipment, the outbreak didn't happen because there wasn't enough PPE in these countries, but there was a major effort developed to look at the implementation of PPE and the specifications that were part of it, and we can talk about that. In terms of the pre-deployment training and clinical management, these were all elements that were part of the work. Major effort by WHO to spend on pre-deployment training of people that went into the field. And the clinical management team, it's an unprecedented amount of attention that's gone into the clinical management side of this outbreak, and it's one of the areas that our department, Service Delivery and Safety, works most closely with the outbreak teams as well as on IPC. But really, before this work, in terms of clinical management, I really don't think you had this on the radar screen. The whole set of guidance documents that were there that related the sort of different parts of the evidence and review. You can see the different pieces of it, both in terms of case management and community mobilization, surveillance, burial, travel. All of these are available on the website. I think there's some questions as to how much in these situations do you need to get evidence out there in the field and how much you just need to go and start doing stuff. Clearly there's a balance to be struck, and one of the works that WHO had tried to do was to bring in our Guidelines Review Committee to have them looking at rapid evidence reviews. And I think there's a lot of cleanup that needs to happen now, but it was an amazing balance between evidence and action. I'll skip ahead just briefly in order to be able to finish with some of our points on health system recovery, but the disease detection work And particularly the work with the Emerging and Dangerous Pathogens Laboratory Network was extremely important. This is a group of 23 WHO collaborating centers that were working on deploying labs, and there was a deployment of 32 labs in the 3 countries. And now we've gotten down to lab capacity, lab testing capacity in less than 24 hours, and this is also obviously part of the vaccine work. The other countries where there was work done, Senegal was declared Ebola-free in October. There was the case that came into Dakar in August. In October 20th, Nigeria was declared Ebola-free. That was a major, major concern for WHO, and an area where we depended on our colleagues from the polio program with their capacity to track cases and use laboratories to really attack the work on Ebola. And Mali declared Ebola-free on January 18th. The preparedness and monitoring work continues. This is a snapshot of some of the checklist or the dashboard that exists for different countries looking at preparedness. This is the link to it, and we can definitely share that afterwards. And that ties very nicely in with the recovery work that has been going on, and I'll finish with this. The work that the countries now have to do is really looking forward in terms of building back the health systems and the health sector that's there. The linkages with preparedness and some of the regional solutions are clearly there, and it really seeks to address key health system constraints. And this is one of the survivors, one of the youngest survivors leaving the health center where he's got his certificate under his arm saying that he's Ebola-free. These different phases has been a unique way, different from previous outbreaks, of looking at some of the recovery where you have not big, broad lines drawn between response and recovery, but you have an early recovery effort that for future work, and clearly in WHO's reorganization, will be part of the response work around some of the trends. There was major impact on the health systems. You can see outpatient visits declining. This is from the Liberia Recovery Plan. And also declines in institutional deliveries and treatment for malaria and immunization, and other areas non-essential, or at least deemed non-essential, such as family planning visits. These have dropped by 90%. The 4 core areas that we really worked on was IPC and patient safety, surveillance, strengthening the essential package of services and the health workforce, as well as in the background looking at supply chain issues and community engagement. And that was really the bridge between the response work and this longer-term activity. And I'll just highlight on this one slide, without going over all of the numbers that are there, these 6 national consensus workshops and these national health systems recovery plans, which have been presented, as I said, at the World Bank meeting, and now the Secretary General will have them looked at the July 10th meeting coming up. So this provides kind of a frame of a broad set of activities looking at from the very early side to the recovery side and where these countries are going. We have some of our colleagues from those countries in the room. I encourage you to talk to them about what's happening on the ground there. And with that and that framing, I'm very pleased to join you and very pleased to be part of today's activities. I give it back to Benedetta and Professor Ndoye.